All right, well, thank you so much, everyone, for being here. It's such an honor to be speaking to such a big group of people who are fighting for such an important cause. And before I get started, I want to thank Carol and Ken Engelhardt, who have kindly set this event up, hosted myself and Natalie for the weekend, and been incredibly kind and hospitable the last few days. I've been sort of going from place to place today and yesterday. I've spoken at the University of Minnesota to medical students, to doctors, to others, and this is really a absolutely momentous moment for our cause and for this struggle. And so it's my honor to be speaking to you tonight on the struggle for Medicare for all, where we've come from, where we are now, and how we get to where we're going to be. So without further ado, I'll get started. So I want to begin by giving, in about 90 seconds, 100 years of history in terms of the struggle for universal health care and where we've come from. So as you're no doubt aware, this is not a new battle. This is not a new struggle. And depending upon when you, who you ask, it's probably been 100 years ongoing. And, you know, probably it began at the national level during the New Deal, during the administration of Franklin Roosevelt, a time of progressive change, a time of reform, and you know, Roosevelt came very close to including national health insurance, as it was called then, in Social Security. But ultimately, he decided that there was a political danger in including Social Security, in tying national health insurance to Social Security, and he was afraid it could sink Social Security, so he walked away at that moment from that cause. Although later in his term, in his final term, you know, he gave a famous State of the Union address, Second Bill of Rights address, and he spoke about healthcare as a human right, among other social and economic rights that everybody in America should have. And he died not too long after, but the cause continued. And in the post-World War II period, there was a new movement for national health insurance. And this time, Harry S. Truman, then president, did embrace it. In fact, he ran on national health insurance when he ran for president and helped him win an election, and a major national campaign for Medicare for all, which was not called back then, but a similar kind of reform, national health insurance, ensued. But again, that went down in defeat. The American Medical Association mobilized across the country from coast to coast to bring down national health insurance. This was a moment of McCarthyism. It was sort of slandered as being a, you know, Soviet plot, communist sort of mission, and so national health insurance went down in flames in the late 1940s, early 1950s. So, you know, subsequent to that, the architects of that plan thought to themselves, what can we salvage from this concept? And what they came upon was Medicare, basically narrow that idea to a program that only applied to older Americans. And ultimately, that concept was embraced by JFK, and after his assassination, by Lyndon Johnson. And so in the top right-hand corner of the screen here, you can see, or maybe you can't see if you're sitting all the way back there, but try to imagine it, Lyndon Johnson signing over the first Medicare card to Harry Truman in a symbolic gesture, because this cause, in some respects, had begun with him. But obviously, that wasn't what the country needed. And so within a few years, a new chapter in the struggle for a universal healthcare system began again. And the idea was to expand insurance to everyone in the country, not merely to one segment of the population. So in the late 1960s, but really more so the early 1970s, a new chapter began, and in the center of the middle middle of this bottom of the screen, you will see a very young Senator Ted Kennedy, who is proposing his Health Security Act in 1971. And that bill is basically the same as the bills that we are pushing for now. It was a single payer. Again, it was not called Medicare for all then, but that's effectively what it was. And Kennedy, this was proposing this during the administration of Richard Nixon, pictured in the bottom left. Not that anyone needed me to point that out, but Nixon had to respond. He couldn't simply not have a plan of his own. He proposed a sort of public-private hybrid kind of model. Okay, and as it turned out, neither plan won out. Nixon obviously is impeached. The country derails the discussion about healthcare reform. And in the late 1970s, there's a conservative turn in the country, and then Ronald Reagan is elected, and there's an even more firm turn in the rightward direction, and national health insurance falls off of the national discussion, falls off the political agenda entirely. And a chapter in history is closed, and healthcare reform history is closed. The interesting thing is that, in some ways what survived of that era was the Nixon plan. The Nixon public-private hybrid plan was basically what Democrats in subsequent years would embrace for the most part. So Bill Clinton in the early 1990s, when healthcare reform swung back into the political discussion, basically endorsed a program that was similar in most respects to the Nixon plan, a sort of public-private hybrid. Now, Clinton obviously did not succeed in that, and it wasn't until 2010 that another major piece of healthcare reform legislation was signed into law by Barack Obama. The Affordable Care Act goes into effect, and it's the first big healthcare coverage expansion since 1965, when Medicare and Medicaid were signed into law. So the first question we have to answer, and which is at the center of our political debate now, is why wasn't that enough? Or why isn't that enough? Or why can't we tweak that? Or why can't we slightly expand upon the Affordable Care Act to get to where we need to be? And so the first part of my talk, I'm going to be explaining and showing in facts and in stories some of the reasons why this status quo is not enough, and why expanding upon it won't be enough. So the first issue, which is going to be something that is very familiar to everyone in the room, is the fact that uninsurance remains an enormous problem in this country. So this is just a figure showing the rate of uninsured Americans from 1963 to 2018. And you can see that before Medicare and Medicaid in 1966, there was close to a quarter of the country was uninsured. And that fell after those laws were passed. And it nadered in the 1970s. But it grew in the 1980s as Reagan started to cut Medicaid. And it persevered, and it got worse in the Great Recession. And yes, the Affordable Care Act, which went into effect in 2014, did a lot to reduce it, but we're still at 9% of the country uninsured, and 6% I learned yesterday in Minnesota. But that's going to only get worse even if no adverse actions are taken by this administration. The Congressional Budget Office estimates that there are 29 million people uninsured in this country now, and that is estimated to rise to 35 million over the next decade. So this is sort of the price of inaction. 35 million people uninsured. And, who are the uninsured? I think, 10 years ago, there was a time when people spoke about uninsured people as being so-called young invincibles, this idea that they were people who might, young people who might have money but didn't think that they had health problems or needed medical care, so just didn't bother to get health insurance. And that's total hogwash, right? Who are the uninsured? The people who can't afford to get health insurance, by and large. And that's why you see that even though overall uninsurance rate is around 9%, about a quarter of poor people and about a quarter of the near poor, these are working class people, are uninsured. There's also major racial inequalities and injustices in who gets health care in this country. And I don't think I need to tell you that, but the numbers make it quite clear. You have more than a quarter of individuals of Hispanic ethnicity are uninsured, 15% of black individuals, much higher than the proportion of white individuals. So this is a class inequality issue, and it's a racial injustice issue. And why does it matter so much? And again, it might seem obvious, but you'd be surprised. Not everyone totally understands how much of a problem this is. You still hear on TV now, politicians will say, hey, if you're uninsured, you can still show up at the emergency room. They're not going to let you die in the streets. The reality is that people are dying. People are dying every day from lack of coverage. For one thing, they're simply not getting the health care they need. This is a figure just showing the amount of medical care that people get based on whether they have insurance or whether they're uninsured. This whole idea that uninsured people are using the ER a whole lot because they don't have a primary care doctor. They're not using the ER a whole lot. They're using the ER about the same. What they are using less of is every other type of health care. They're just not getting the care they need. You can see this when you look at what happens as people who are 64 turn 65, people who are 64 and uninsured turn 65 and get coverage through Medicare. What happens? Their use of healthcare rises. They suddenly get more doctor visits, get more procedures, get more hospitalizations because they've been going without needed care for many years. The problem is far broader than that. When you say 9% of the country is uninsured, that actually doesn't fully explain the gravity of the problem. Because those surveys are basically done by asking someone, are you insured right now or are you uninsured? And you may say, I have coverage. But it may turn out that actually just 4 months ago you had lost coverage and you got it back, okay? So those kinds of disruptions are very frequent. And if you add up all the disruptions that people have from lapses in coverage, but if you also look at people who don't become uninsured but change healthcare plans, you have a story of disruptions in the delivery of healthcare with serious consequences. This is a study that looked at low-income people in 3 states and found that those who had some kind of disruption in coverage, even if it was temporary, wound up having to change their doctor frequently, change their prescription drugs. 34% reported skipping dosages of medications or stopping taking prescription drugs. And I work in Massachusetts, okay, the state that implemented Romney Care, which was the precursor for the Affordable Care Act. I think we have the lowest uninsurance rate in the country, perhaps. I think it's under 3%. And I see this all the time. I see patients, including in the intensive care unit, who had lapses in coverage, or maybe their coverage changed and their formulary changed as a result, and the insulin they were getting on day 1, when that coverage changed, was not the insulin that was covered anymore, and they weren't able to get it, and they went a few days trying to get a new prescription and wound up getting very sick because they weren't able to get the drug they need. And that's because we have a completely crazy system in which people are constantly cycling through plans. You can have Medicaid and make a little too much money, and suddenly you're no longer eligible for Medicaid. You could have private insurance and suddenly lose your job and no longer have that. You could have private insurance and, through your spouse, and you could have a divorce and lose that coverage. So there's a million ways in which Americans are cycling in and out of coverage, in between plans. The whole idea that you can keep your health coverage in America is a total it's a total lie, right? And so when politicians say, under Medicare for all, people couldn't keep their insurance, the answer should be people can't keep their insurance now, right? And in fact, under Medicare for all, they could. Another side effect of being uninsured seems to be that it actually causes depression. This was a study it was an experiment, really. You may have heard of the Oregon Medicaid experiment. Effectively, the state of Oregon wanted to expand Medicaid, but it didn't want to spend money to actually cover the whole population. So they created a lottery to see who could get it. Welcome to America in the 21st century. We basically are running experiments of health coverage. It was obviously terrible for those who didn't get covered. It opened up a very exciting opportunity for healthcare researchers who could look at what happened as a result. So this is basically an experiment. It's a lottery. It's a randomized trial for all effects and for all intentions and purposes. And the takeaway from this slide, in which you don't need to see it, is that getting coverage actually reduced rates of depression by 9 percentage points. And why is that happening? It's maybe in part because people are getting better treatment of their mental illness, but probably even bigger is simply the fear and the psychological strain and the just incredible anxiety of not knowing whether an illness could devastate you financially or whether an illness might mean not being able to get medical treatment. This has been studied in many studies over the years. Does lack of coverage cause people to die? There's been different ways of looking at this. This was a systematic review that was published a couple of years ago that looked at the whole literature of studies that analyze the effects of lack of insurance on mortality, and the takeaway here is yes, if you don't have coverage, you're more likely to die a premature death. And why is that? I mean, again, this isn't rocket science, but in my practice, so I work in Boston, in Cambridge, Massachusetts specifically. I work in an intensive care unit, and I have certainly seen people who have wound up in the intensive care unit because they had lapses in coverage or years without coverage and went without needed care for common chronic illnesses, things like diabetes, hypertension, wound up with life-threatening complications of those illnesses. We tried to sort of examine this in a more systematic fashion by doing a study and looking at what happens to young people who are teenagers in the United States when they go from teenagers to young adults, and what happens to the rate of diabetic ketoacidosis. So diabetic ketoacidosis, for those who are not aware, is a life-threatening syndrome that develops when people with typically diabetes type 1 who require insulin stop taking their insulin. The acid levels in the blood go up, the breath quickens, confusion sets in, nausea, vomiting, and it can actually lead to death if not properly treated. Long story short, we looked at the US and we looked at Canada, and we found that hospitalizations for diabetic ketoacidosis in the US spike when teenagers become young adults in the United States, and you don't see such a spike in Canada. And why is that? Well, there may be more than one reason, but likely an important reason is that as children become adults in this country, they often lose coverage, and when they lose coverage, they lose access to the medicines they need. And this was dramatically and terribly and tragically demonstrated by the case of Alex Smith, widely reported, and a story that many of you may have heard. Alec was a man who had type 1 diabetes. He was 25 one day, and then the next day he was 26, and when he turned 26, he lost his health coverage. When he lost his health coverage, he didn't really have a lot of options to get coverage affordably. He made around $35,000. It was too much money for Medicaid. He was, a working class man. The premiums that were available, if he was going to buy a plan, were going to be $450. The deductible was going to be maybe $8,000. And so he decided to go without health coverage. And he was found dead in his apartment. There was an empty insulin pen in his apartment, and the autopsy showed that he had died of diabetic ketoacidosis. And his mother has now become a leading advocate in the fight for insulin access for everyone. But just a tragic story that probably is representative of many other stories. Now, if the only problem we're contending with right now was the uninsurance issue, it would be a big battle, and you would need to do a lot to fix it. But maybe you wouldn't need to go all the way with Medicare for all. I don't know. But the reality is that it's not the only problem. The other problem that's facing this country in a major way and is just as harmful is the problem of underinsurance. So I like to show this slide when I talk about this. So this is from a satirical publication called The Onion, and the headline is, and I'm going to explain the joke, which is how you know it's a funny joke. So don't worry, you don't need to be able to see the slide. The headline is Company's HR Manager Really Pushing Infinite Deductible Healthcare Plan. And so the gag is that the boss has this new plan that he's pushing out to the workers. It's really great. You can use it anywhere. It covers every kind of healthcare service. There's no networks. The only downside is you have to pay 100% of the costs out of pocket. All right, so it's obviously a satirical publication, but I think that the fact that it's showing up in a satirical publication suggests that this is an issue with very broad salience to the population. So just to put a couple numbers on it, so deductibles are the amount you pay out of pocket before insurance kicks in. So it used to be, 10 years ago or so ago, that about half of workers had a deductible. Now it's basically everyone. The dollar amount of deductibles has been skyrocketing from $300 on average back in 2006 to now $1,400. That's for single coverage. It's probably about double for family plans. That's for people who are covered through their employer. Now, let's say you buy coverage on the marketplaces that was set up by the Affordable Care Act. Those deductibles are far higher, and this is the kind of these were the kinds of options that Alex Smith was considering. So, all you can focus on here is the deductible for the Silver plan. That's the plan that most people wind up buying. The Silver plan deductible for a family in 2019 was $8,000, and that sounds like a lot of money, and that is a lot of money. But I want to point out another fact. The blue bar is the average assets of the American family, the mean liquid assets of the average American family. It's about $5,000. Now, a lot of people have a lot more than that, meaning that a lot of people also have a lot less. But can you imagine if all the money that you have to move around is $5,000, an $8,000 deductible basically means that you are uninsured for all intents and purposes. You don't even have enough money to cover your deductible. And so as a result of that, what we're seeing is that even as we've seen downward trends in the number of people who are uninsured, we're actually seeing upward trends in the number of people who are underinsured. Okay, so right now we have, this is a figure that's showing the number of people who are underinsured. In 15 years ago, there was 16 million, and it has been steadily rising, and we now have 44 million people uninsured. So if you add up the underinsured and the insured and people who have lapses in coverage, you get to around at least 87 million people with some inadequacy in their health coverage. So this is not a problem affecting a small proportion of the nation. It's a problem that's affecting growing proportions. And in fact, this definition of underinsurance is very narrow. By other definitions, perhaps most of us would be considered underinsured. And why does underinsurance matter? Well, it's ruining people financially. Okay? So those of us who are underinsured, 30% are facing medical bill problems. 20% are being contacted by collection agencies for medical debt, and once you're contacted by a collection agency, obviously your credit is now in the toilet, and that can have major ramifications for your ability to get a home, to get a car. And so we're seeing this in the media as well. We're seeing this on our Facebook feeds. We're seeing this on our Twitter feeds. People are crowdfunding for their medical costs. People are turning to GoFundMe to raise money to cover their deductibles. And you see these headlines all the time. And the thing is with these stories, if you click on them, or maybe you know people, or maybe you yourself have been in this situation, frequently these individuals have insurance. It's just not good enough to actually cover the costs of illness. There's been a slew of stories that have looked at this from another perspective. People who have had hospitals come after them and suing them for unpaid bills because either they were uninsured or underinsured. This is a recent story about UVA, reported by Kaiser Health News. So just let me give you one example of what happened to this woman. Her name is Heather Waldron. She was 38 years old. She's an insurance agent. She had emergency surgery for an intestinal malformation. And she was grateful for that surgery, and she did well. But she, it turns out, was uninsured. I think, she attributes to a computer error. For some reason, there was a lapse in her health coverage. So she was on the hook for $164,000 from the hospital. They sued her. They put a lien on her home. She was basically broke at that point. She was sued on food stamps. Foreclosure proceedings were begun on her home. And at the current stage, she's looking to talking to bankruptcy lawyers to go into bankruptcy. They reported another story, a woman named Shirley Perry. She was a nurse at UVA. She got sick. She lost her job. In this country, when you lose your job, you lose your health coverage. She needed medical care from her former employer, and she didn't have adequate coverage, and so she was on the hook for more than $200,000 in medical expenses. She soon died at age 51, and at the time of her death, there was a lien on her home, and her home was being auctioned off after her death. Also reported by Kaiser Health News. So these are stories that are playing out across the country. Having health insurance is not good enough. And you often hear surveys that say that X percentage of people are happy with their health coverage, but you have to always ask, the coverage is often, you don't often realize how inadequate the coverage is until you're very sick. It's only when you get sick and you're on the hook for those bills and you need medical care that suddenly you realize that coverage was no coverage at all. It's a defective product. But the harms of the current system, the harms of the American healthcare financing system are not simply financial. The reality is that a lot of times to avoid being put in those straits, people are just avoiding healthcare altogether. So for instance, a quarter of the underinsured say they didn't fill a prescription due to cost. This is an example of a gentleman who was in that situation. This was a man named John Crane, again reported by Kaiser Health News. He had lung cancer. It was progressing. His physicians recommended a drug that cost around $160,000 a year. That was the sticker price, but it was brought down by the insurance company, but his copays still required him to pay $6,400 out of pocket. So he decided, I'm just not going to do it for now. So again, the numbers support that. 24% of the underinsured say they didn't go to a doctor in the last year because of costs. And overall, about 35% of non-elderly adults in the United States say that they didn't get some health care they needed in the last year because of cost. And this has dramatic effects on people's health. This was one study that found that raising copays on the elderly by as little as $5 to $15 caused their use of doctor visits to decline substantially, but at the same time, their hospitalizations rose, suggesting that they couldn't afford those copays, were not seeing the doctor, and were winding up with complications of chronic illnesses in the hospital as a result. There's been studies looking at what happens with individuals with high deductible health care plans. Individuals with diabetes who are pushed into high deductible health care plans, what happens to their health? These are quasi-experimental studies. There's a comparison group of similar people who keep higher quality coverage. They wind up in the ED more, they wind up in the hospital more. As I mentioned, I work in the ICU. I'm also a pulmonologist, so I see a lot of patients with pulmonary disease like COPD, emphysema. One thing I've heard from many patients is, I actually can't afford this inhaler that I'm prescribed, so I haven't been taking it, or I'm taking it once a day instead of twice a day because I can't afford it. Okay, often seniors with fixed incomes. It turns out that asthma inhalers are rising in cost, and people are not taking them. We did a study looking at how this plays out for the COPD population and found that 25% of individuals with private insurance and a high deductible plan who had emphysema said they delayed filling a prescription because they couldn't afford it. And we also found that those who had high deductible healthcare plans and COPD were being hospitalized more and was showing up in the ER more. Again, suggestive that the lack of adequate medical care was causing their illness to get worse and for them to require hospitalization. I want to make the point that we need Medicare for all without cost sharing. So cost sharing is co-pays, deductibles, and co-insurance. The only purpose of co-pays, deductibles, and co-insurance is to keep people from using healthcare, right? That's the only purpose. And sometimes you'll hear someone say, well, why can't we just make them sort of modest or reasonable? And the reality is that for well-off people, that might not matter, but for working class people, it will, and they will go without health care that they need. This was a randomized trial that took people with heart attacks and randomized them to free medicine and to copay medicine. And you know what? The people who had the copays didn't take their medication as much and actually had more recurrent vascular events after their heart attack. Again, their health was being harmed. And it was particularly harmful for black patients. Why? Because on average, we can presume they had less resources and were more likely to go without needed care. So this is a racial justice issue. Finally, one of the most heartbreaking studies I've read in a while, again looked at the effect of having high deductibles, and it looked at patients, women with breast cancer. And what these study authors found was that women with breast cancer who were pushed into a high deductible healthcare plan delayed diagnostic imaging by 0.6 months, delayed getting a breast biopsy by 2.2 months, delayed getting a diagnosis effectively had a delayed diagnosis by 7 months, and their initiation of breast cancer chemotherapy was delayed by 8 months. And it's hard to imagine a more heartbreaking manifestation of the way we choose to pay for healthcare in this country. All right, the final reason why I am going to say we need Medicare for all and none of the alternatives is because for the following. You might hear what I've said and said, okay, yes, uninsurance, that's terrible. We need to do something about that. Let's cover the uninsured. And you might hear me say, all right, we need to upgrade coverage for everybody else to get rid of the copays, get rid of the deductibles. And you might say, that also sounds nice. Can we actually afford that? Now, I would push back immediately. The whole idea that people are going to use unnecessary health care just because it's free is quite silly. I was recently actually on vacation in Scotland. I was on a honeymoon. This is last month. And I wound up with a very minor medical problem. I'm fine. Everything's fine. But I went to the emergency room in Scotland. I got seen by a doctor. I got a prescription in the ER, and I was given it to take home with me. Really convenient. And I knew that in the UK there weren't really copays, but I actually wasn't sure if that applied to tourists, right? I was there for 6 days. Like, what kind of right do I have to just, use these services? And I asked, do I, owe anything? And the doctor said, or the nurse said, I think, actually, no, all healthcare for emergencies in Scotland is free. And I was like, that's great. And so what's the danger there? Is there really a moral hazard? Am I going to go back to Scotland just to get another free medication on my next honeymoon? Oh wait, no, Natalie, I'm just joking. There's no next honeymoon. I would like to go back to Scotland, though. I will confess. Hopefully not winding up in the emergency room. But even putting that aside, it is true that people will use more health care, and we do need savings to counterbalance that, right? We spend a lot of money on healthcare in this country. That's plenty of money, but we don't want to spend more. We don't want costs to rise. So it turns out that Medicare for all is the only actual reform that will produce the savings you need if you want to cover the uninsured and expand coverage for everybody else. So why is that? Well, first of all, you have to look at one of the biggest areas of waste in the American healthcare system, and that's in the enormous administrative costs of our healthcare system. The money spent on billing, coding, bureaucrats, and sky-high insurance salaries that is money that could actually be used for paying for people's healthcare rather than lining the pockets of insurance companies. In the United States, we spend about 31 cents for every dollar we spend on healthcare, on billing and administrative activities. That's double the proportion of Canada. And why is that? Well, look at the insurance industry for a second. So the private insurance companies, for every $1 of premiums they collect, they use 12 cents of that for their overhead, for contracting with doctors, contracting with hospitals, advertising, marketing, plan design, for their stockholders, for their profits, for their executive salaries, okay? 12 cents of every dollar. That compares with 2 cents of every dollar that goes to traditional Medicare's overhead. Okay? And if you consider that we spend $3.5 trillion on healthcare a year, that is not chump change. That difference is an enormous amount of money. And that number, 2% for traditional Medicare, turns out that's basically the same as what they're doing in Canada as well. There is enormous savings to be unlocked here, but only if we move to a single-payer Medicare for all system. It's not, the waste is not just in the insurance side, though. It's also on the provider side, because hospitals and doctors' offices are having to contend with innumerable different insurance plans. They're having to contest denied charges. They're having to chase after, in some cases, unfortunately, they're chasing after patients. And that is a huge amount of money. Let me give you one statistic. Duke University Medical Center has 1,800 billing clerks for less than 1,000 beds, meaning they have nearly 2 billers for every bed. That may be revenue maximizing for the hospital, but it is a complete and utter waste for society, right? So U.S. hospitals overall, you put it all together, you add it all up, they spend about 1/4 of their revenue on billing and administration, double the proportion of hospitals in Canada and Scotland, where they give hospitals lump sum budgets for all their expenses, and they don't actually have to write individual bills for patients. And as physicians, there's really a big benefit in moving to Medicare for all. We spend enormous amounts of time and resources interacting with payers. So interacting with payers is sort of a euphemism for fighting with insurance companies. But this is just a chart showing the Ontario and the US. So physicians spend more time interacting with payers per week, but we also hire a lot of nurses who spend on average 20 hours per week interacting with payers, and our clerical staff spend another 53 hours per week on interactions with payers. And if you add this all up, it's an enormous amount of money. In the United States, we spend over $80,000 per physician simply to cover the costs of their interactions with the insurance companies. 4-fold higher than in Ontario. Enormous amounts of money. And the final way to look at this is the amount of revenue that gets consumed simply by the cost of writing the bill. So in the United States, this is at one academic medical center. For an ED visit, the total payment that a hospital receives for an ED visit, 25% of that is simply consumed by bill processing. All right, just the cost of writing and processing the bill. So this is an enormous amount of waste. And it can be extracted from the system. We know it can because we can see what traditional Medicare could do, and it can be done for the country at large. Finally, Medicare for All would also uniquely allow us to bring down drug prices. And high drug prices are a major reason in this country why people are going without the medications they need. A Medicare for All system could negotiate on the federal level with drug companies, and if the experience of other nations in Europe is any guide, if the experience of the VA is any guide, we should be able to bring down brand name drug prices by at least 50%. And that's going to produce at least $150 billion per year in savings. And all that administrative garbage that we could cut out of the system would give you about another $500 billion in savings a year. That is more than enough money to cover all of the costs of covering the uninsured and expanding and improving coverage for everyone else. And that's why we need Medicare for All. No other plan is going to cover everyone. No other plan is going to get rid of the copays and deductibles, and no other plan is going to come close to producing those kinds of savings. So not a public option, not expanding the ACA. They may help some number of people, but they're not going to solve those problems. So I want to sort of close out by talking a little bit about where we are today and where we're going. I spoke a little bit, I started this talk by speaking about the history of the healthcare reform struggle. I spoke about how it sort of began in the New Deal and how it a new chapter was opened after the implementation of Medicare, and how that chapter was closed, with the election of Reagan and the turn of the nation to the right. But a new effort was made to get that conversation started again. And this is an area where my organization, Physicians for a National Health Program, did something very important. And it put this idea back into the national discussion. In the late 1980s, this organization was formed, 1986 to be precise. In 1989, they laid out the principles for a single-payer Medicare for All system in the New England Journal of Medicine. And that was widely read. It was revised in 2003 in the Journal of the American Medical Association. And that same year, Representative John Conyers introduced a bill into the House of Representatives called H.R. 676, the Improved Medicare for All Act. This bill was introduced every year after that, 2003 onward, but not really supported by all that many Congress people. Okay, it was pretty much not in the mainstream, I think is one way to put it. I got involved in Physicians for a National Health Program in a significant way when I was in residency. This is a picture, I think, from 2010 or 2011. It was the Occupy Wall Street era when there was a sort of turn in the national discussion towards the issue of inequality, right? And health inequality is a really important part of the larger inequality issue. Economic inequality causes health inequality, but health inequality also causes economic inequality. They're two twin snakes that sort of feed off of each other in a very pernicious way. And at that time, again, we were saying that one way to address that the 99% needs healthcare, right? Using that language. But the reality was that it still was very much an issue that was not in the forefront in the national political discussion. In 2016, we published a revised version of the physician's proposal that had originally been published in 1989 and 2003. Basically, we said, all right, well, it's been a while. We have the Affordable Care Act, and a lot's changed. We need a new statement to sort of put out our principles and lay out a plan. And at that time, it so happened, that effort had been underway for a couple of years. It so happened at that moment that there was a primary campaign. There was a Democratic primary, was ongoing, and healthcare was a major dividing point in that campaign. And so this attracted a lot of attention, and we got a lot of news media about the fact that doctors were saying, actually, single payer is the right way to go. Medicare for All is the right way to go. We had thousands of doctors sign on, and medical students and allied health professionals and others, and that was an exciting moment. Let me just say very briefly about what's in that program, in case you're not familiar. It's pretty simple. I broke it down in one slide. Everyone's covered. Benefits are comprehensive. No copay deductibles or coinsurance. No duplicative private insurance that's going to simply cause waste or give some people, allow them to cut the line. Hospitals will be paid by global budgets so that all of their operating expenditures are covered. None of that waste and none of that billing. Coverage of long-term care, that's an important part of healthcare. We'd plan new health infrastructure, and we'd subsidize the educational costs of the healthcare workforce. So that's in the physician's proposal. And after that moment in the primary, when suddenly single payer had a lot more national attention, what happened? Well, Donald Trump got elected, right? And we didn't see that coming. Not many people did. And obviously that was distressing and frightening, as it remains true now. And in addition to all the other harm that we knew that Trump was capable of, one fear was that, look, this issue is going to fall off the table entirely. We're going to be simply paying, defense, right? We're going to be on the defense. They're going to be attacking Medicaid and Medicare and trying to dismantle all the safety net programs that people use. And so, maybe this Medicare for All thing is going to be falling from the agenda, and we're just going to be playing defense. Well, us and all of our allies and the grassroots and disability rights groups did play defense and did fight back when they tried to repeal the Affordable Care Act and did win, right? And did defeat the repeal of the Affordable Care Act. But something else happened at the same time. The fortunes of Medicare for all and single payer actually continued to rise. Why? I can't tell you for sure. It was the momentum, it was the resistance, it was many factors, but from that moment on, the number of Democrats in the House of Representatives signing on to the bill in the House climbed and climbed and climbed and climbed until a majority of House Democrats were signed on to H.R. 676, that bill that had been in the House since 2003. A new caucus was formed in the House of Representatives, just devoted to Medicare for all. And then something happened in the Senate. So Bernie Sanders, actually did have a Medicare for all bill in the Senate for a number of years, and there was precisely one sponsor of that bill, and that was him. So he was sort of a lone voice. But something happened in 2017 when he launched a new bill. He no longer had 0 co-sponsors. Now he had 16 co-sponsors, including many other people who are now running for president, including Elizabeth Warren. So that was in 2017. And then the issue continued to move into the mainstream. Obama himself in late 2018 said something along the lines of, Medicare for all might be a good new idea. It's not a new idea, but we'll take it. We launched the successor to H.R. 676, Pramila Jayapal, Congresswoman Pramila Jayapal. I didn't actually mean to do this, but...
Three speakers. I'm going to introduce them all at once.
Well, you're hearing me speak enough. I actually didn't even mean for this to go on. Okay, anyway, we launched the new bill. She launched a new bill, and it's a very good bill. It is a Medicare for all bill. It's a single-payer bill. And again, over 100 House Democrats signed on to that bill. A new version of, the Sanders bill was he introduced in 2019, again with much support. And in the background, there's been rising popular support, right? So the Kaiser Family Foundation, which has been tracking support for single payers since 1998, when there was 40% support, now finds over half. Most polls find over half of the country supports Medicare for all. We do even better on some polls. This 2018 poll found 70% support. So this is the one I like to show, and I'll keep showing it until we get a better one. And how about physicians? Well, there's not a lot of great polling. The last high-quality poll that was done was about 10 years ago, and it found 59% of physicians supporting Medicare for all or national health insurance, and that is a really important fact. As I said, in the 1940s, the American Medical Association sunk national health insurance. We can't let that happen again, and we're not going to. And we had a little victory in this regard this year. The American Medical Association actually signed up, got on board with something called the Partnership for America's Healthcare Future. This is a coalition of not organizations, corporations. The pharmaceutical companies and the insurers are on board, and it's basically an organization that has one purpose, and that's to drive a stake through the heart of the Medicare for All movement. And the AMA joined that shamefully, but in particular, student members of PNHP took action. Student members of PNHP, who are also a member of the AMA, went to the AMA and introduced a resolution that would end the AMA's opposition to Medicare for all. At the same time, they organized, in coalition with many other organizations, a protest outside the AMA's national convention. So this was all happening around the same time. And you know what? The vote in the AMA was only narrowly defeated. It barely was defeated. That was huge news in and of itself. And at the same time, there was another victory, which was that the AMA did withdraw from the Partnership for America's Healthcare Future, a not small feat considering history. So, this is one victory, and we're going to need victories like this in order to get to where we need to be. But the reality is that we're moving in the right direction. We have made incredible strides in the last few years. We've opened up a new chapter in the history of the struggle for universal health care in this country. And I really do believe that this will be the final chapter. You know, this will be the final story. How far into it, I don't know, and nobody knows. But I have no doubt that we will win in this struggle, that we will achieve Medicare for all, and that those tragedies, those stories, those people who are dying every year, every day, because they can't get the health care they need, will no longer be that will be in the past and not in the future, that as doctors we'll be able to focus on taking care of our patients and not fighting with insurance companies, and that patients will be able to focus on getting better and recovering from their illnesses, not worried about going bankrupt, going broke, or being put into poverty. And I'm very excited to see that happen, but let's make no mistake, we have a big fight ahead of us. So thank you so much for hearing me today.